Okay. Thank you everyone for participating in the poll questions. And once again, welcome. I would like to take this opportunity to introduce you to our first panelist or first presenter for the evening, Miss Nicole Ennis. Uh, she will be discussing, or she will be providing actually an overview of the CARPHA Medicines Quality Control and Surveillance Department at the Caribbean Public Health Agency. Ms. Nicole Ennis is the head of the Medicines Quality Control and Surveillance Department at the Jamaica campus of the Caribbean Public Health Agency. She has an extensive experience in the implementation of laboratory quality and safety systems from her previous role as Quality Safety Manager. She holds a Bachelor of Science in Biology from Yale University and an Erasmus Mundus Master's degree in Quality Management from Laboratories from Gans University of Technology. Ms. Ennis is also responsible for the management and maintenance of the department's testing services for medicines to verify their quality and also their efficacy. She also leads in the department in regards to its collaborative work within the region and regional partners to strengthen its testing services and also the system for medicines regulations in the Caribbean. I take this opportunity to invite Ms. Nicole Ennis to start her presentation. Nicole, please take it away. Thank you.
Thank you very much, Pat, for the wonderful introduction. And thank you, Tamu, for the opportunity to participate and present in this very important webinar series. Good evening, everyone. I will be presenting on the Jamaica Office of CARPHA, the Medicines Quality Control and Surveillance Department, MQCSD. My outline for the presentation is speaking on MQCSD's role in supporting national medicines regulatory authorities and procurement bodies in medicines regulation and improving access to essential medicines, which includes those used to treat the topic of this evening, diabetes, the impact of our work in the Caribbean, and the MQCSD post-market surveillance program. So at some point in our lives, the probability is very high that we have had to take a medication. And when we go to be treated by our physicians, when we go to the pharmacy, we want and need to be confident that what we are getting is actually what is on the label, and that it will treat the target ailment and that the medicine will be safe. And when you look at all the critical components for an effective medicines regulatory system, in addition to comprehensive legal framework, sustainable funding, strong government mechanisms, you see that it is important to have a competent quality control laboratory. And this is where, for the Caribbean, MQCSD comes in. Our work is mandated by the CARPHA Strategic Objective Health System Strengthening, specifically those for medicines. And as you can see, it's encapsulated in our tagline, assuring safe, reliable medicines, preserving a healthy Caribbean. And so for the Caribbean, as I said, MQCSD is focused on providing reliable, quality, and customer-focused services. So what does that mean for our member states? Our work includes, and at the forefront, a risk-based post-market surveillance program for medicines on the CARICOM market, the development of guidelines, or advocating or adopting standards, policies for medicines, either for our work or at the national or regional level, testing of medicines that may be submitted by our ministries outside of our post-market surveillance program. They may be doing their own national surveillance or routine checks, or perhaps trying to confirm a suspect quality issue with a medication. We also perform regional capacity building in our member states. We collaborate and share information with our key partners, which includes PAHO, the Caribbean Regulatory System, and of course our member states, and maintenance of our ISO 17025 accreditations. As you can see, this is our accreditation scope. We are accredited for chemistry testing of finished pharmaceutical products to the United States and British pharmacopoeias. The standard is the general requirements for the competence of testing and calibration laboratories. And to date, we are the only accredited medicines quality control laboratory in the English-speaking Caribbean. And we were fortunate to receive this accreditation status in September 2017. This is an overview of the CARPHA units supporting regulation of medicines. Our work complements the work of the Caribbean Regulatory System, which recommends medicines for market authorization. They also maintain VigiCarib, which is responsible and supports pharmacovigilance and post-market surveillance reporting. And of course, MQCSD, providing the role of medicines quality control testing. So what is the impact of MQCSD's work in the Caribbean? As a medicines quality control laboratory, we confirm the good quality of medicines. So we're building the confidence of the supply chain and the supply system in the region and in country. We identify poor quality medicines, and these may be substandard, as in not meeting the required test specifications, or falsified. Regulatory strengthening, as I said. So in 2019, we published a post-market surveillance guide for small island developing states to help support our member states in implementing or improving existing post-market surveillance programs. We also look at providing training and also in the advisory capacity as necessary to our member states. Our work provides results that has given our member states, the regulator authorities, evidence needed to take regulatory decisions. So that could mean either continuation of market approval and use, market withdrawal, or non-registration of a product that the application was received, and in one case, the re-adjudication of a procurement. And so now I will speak on our post-market surveillance program. The objective of this program is the systematic, proactive monitoring of selected medicines in the Caribbean for quality, safety, and efficacy. And to do this, we developed with our post-market surveillance working group and also with the Tech Farm, the expanded CARICOM Technical Committee on Pharmaceutical Policy. We use the following risk-based criteria. Those reported to our Ministries of Health or to MQCSD or CRS for quality or suspect issues. Those produced by countries in limited regulatory systems, or perhaps they've had a limited time on the market, which is less than 5 years in a stringent regulator or authority. Those on recognized standard guidelines and in high usage in the region, such as the WHO Medicines Essential List or CRS recommended medicines. Those with formulation challenges, and those with narrow therapeutic indexes. And so why a post-market surveillance program? WHO recommends that quality control laboratories of our function and status should focus our resources on post-market surveillance. It also serves to better align our work program with the CCH4, with the CARICOM strategic priority for advancing initiatives for health and wellness, and with the Caribbean pharmaceutical policy. It provides planned medicine sampling and monitoring system for the region after these products have come on the market. It provides surveillance data to inform decision-making and action, as I spoke about in the previous slides. And this is also in keeping with the integrated surveillance strategy of CARPHA. And it helps to strengthen the systems for medicines regulations within CARPHA with the ultimate aim and goal of improving access to good quality, effective medicines. So the implementation saw a pilot phase which ran for 2 years between 2018 and 2019 with the OECS countries through their pharmaceutical procurement service and the Guyana Food and Drug Department. So this allowed us to get a feel for what could work in the region, what was successful, and what were some of the challenges we could look at addressing for the full implementation, which began in January of this year. And we opened to all 26 CARPHA member states. To date, 16 member states are participating in the program, and we hope to increase this number for the 2021 rollout. So what were the medicines selected for this program? Of course, applying the risk-based criteria, we chose metformin, which again, focusing on the topic of this evening, is the first choice for treatment of diabetes. It's widely used in the region and it's on the WHO essential medicines list. We also took into account and selected warfarin, an anticoagulant, again highly used in the region, and amlodipine, first choice for treatment of hypertension, which you tend to find in diabetics, also on the essential medicines list and highly used in the Caribbean. And then for children, we decided to look at coamoxiclav for oral suspension. So our results today that I'm able to report on, we tested 19 brands or 19 samples for metformin. And we are able to report that 74% met the test specifications. In this case, it was the British and United States pharmacopoeia as applied. We are currently completing testing for the remaining products, and we hope to be able to report to our member states, which we usually do in our quarterly surveillance reports that's shared with the ministries on the results for amlodipine, warfarin, and coamoxiclav. And so with that, I would like to thank you all for your time and attention and encourage you to visit the CARPHA website, where of course you will find the COVID-19 response page. And also if you would like more information on MQCSD. Thank you.
Thank you very much, Ms. Ennis, for your presentation on the regional efforts to proactively monitor selected medicines on the Caribbean market for quality, safety, and efficacy. So without further delay, I would like to introduce our next speaker, Mr. Francis Burnett, who is a consultant in medicine procurement and supply chain management. Mr. Burnett will be presenting on the CARPHA guidelines on the management of diabetes in primary care, with a focus, of course, on access to essential medicines. Mr. Burnett is the former head of the Organization of Eastern Caribbean States Pharmaceutical Procurement Services, which has a responsibility for procurement and supply chain management of medicines and related medical products for its 9 member states. Under his leadership, Mr. Burnett transformed the OECS PPS into one of the world's most successful multi-country pool procurement entity for medical products. And of course, everyone is very familiar with the OECS pool procurement success. Also, he has achieved a 20% reduction in the unit cost of medical commodities. He holds a Bachelor of Science degree in pharmacy from Canada and diplomas in health education and business administration from the University of the West Indies. In 2006, he was honored with the rare distinction of the highest award by the Caribbean Pharmacy Association for having a unique, transformative and enduring influence on the profession of pharmacy in the Caribbean. Mr. Francis Burnett is a recognized leader in managing medicine supply and has served in short-term consultancies in the CARICOM Secretariat, in the Pan American Health Organization, in the United States Pharmacopoeia, and the World Health Organization. He is an avid researcher and presenter, having published numerous articles in scientific journals on medicines utilization, reviews on chronic non-communicable diseases such as hypertension, diabetes, asthma, epilepsy, and mental diseases. I turn the floor over to you, Mr. Francis Burnett.
Thank you, Pat. Thank you, Pat, for your wonderful introduction. I am pleased to have the honor and privilege of presenting the CARPHA diabetes guidelines to our colleagues in the Caribbean. And I thank CARPHA for this opportunity. And I'm also grateful for participants for participating in this webinar. So the focus of this presentation is to present to you CARPHA's document, Module 4, Access to Essential Medicines. Module 4 is one of 4 modules. The other modules haven't been presented in different fora. Access to essential medicines is best described in a schematic diagram, and if we go from left to right, we'll focus tonight on the major components which constitute the important parameters of access to medicines. We look at the selection of medicines, forecasting, procurement, warehousing, distribution, and the last stage in the sequence of access to medicines is the prescribing. Once the doctor writes that prescription, it should be available to the patient at the point of prescribing, pharmacovigilance, and of course, for patients to get a good outcome, we'll speak briefly about patient adherence. So, selection of medicines. An essential medicines list is the first and the most important aspect in access to medicines to ensure we have the affordability and availability to healthcare professionals and to promote rational medicines use. And it should be linked to a standard clinical guidelines. A universal concept for selection of medicines and having the best medicines available in our CARPHA region is the essential medicines are those which satisfy the priority healthcare needs of the majority of a given population and selected after due relevance and consideration is relevance, efficacy, safety, and cost effectiveness. There are thousands of medicines on the market, several hundreds for diabetes. What we make sure to do in the CARPHA region is to ensure the best medicines are available for use in our healthcare setting. And those medicines are intended to be available within a functional healthcare system and should be available at all times in adequate amounts, in appropriate dosages, with due quality assurance backed up by the MQCSD and with adequate information. And it's better to have a consistent supply of a set of core medicines, well-researched and always available, rather than to have a wide basket of medicines and some are available some of the time. In selection of medicines, we had a thorough process, the CARPHA working group, where we looked at the medicines available for the treatment of diabetes. And an important principle in the selection of medicines is what we call the sign level of evidence. The committee looked at, and the best level of evidence is to gather information from randomized controlled clinical trials with low risk bias. In other words, we look at trials where patients are randomized into 2 groups, a placebo group and patients receiving the active meds. Lower down in the level of evidence would be studies such as case control studies, cohort studies, case reports, and the least important evidence is expert opinion by medical consultants. But sometimes we tend to rely too heavily on what experts think. It's not what we think, it's what the randomized clinical control trials inform our decision. Of course, we will take into consideration expert opinion, but it's not the most important in terms of sign level of evidence. We must remind our participants of the importance of an essential medicines list in our environments, because there are several medicines available. All medicines are not created equal. What we try to do in the CARPHA working group and available to the countries is the best medicines available. With that market basket of the best medicines available, and we have an essential medicines list, drug therapy is improved because we will be using those medicines which are most efficacious for diabetes. By having a set of medicines, procurement is enhanced because we will focus on a cost set of meds. Distribution will be reduced, purchasing power, because we'll have larger volumes within specific therapeutic categories, and inventory holding cost is decreased because the inventory holding cost of a pharmaceutical supply system is directly proportional to the number of items in inventory. In terms of public procurement for the Caribbean, we're guided by some key principles. So we've spoken about selecting medicines. When medicines are selected, of course, we need to procure. And there are many examples worldwide of inefficient public procurement systems. We want to make sure in the Caribbean, in all our member states, we have efficient public procurement systems and guided by certain core principles. The value for money means once we procure meds, they're at least benchmarked against the international medium price ranges on the market. Transparency and fairness, those principles are embodied by having good tendering systems where we have tendering committees, not one person making the decision, but a committee, and having an electronic procurement platform so that tenders are submitted online in real time. So there's a gradual phasing out of having tender boxes and suppliers submitting and dropping off tenders, because when this happens, suppliers always submit the tenders last minute, fearful that the information might be disseminated or diverged to competitors. So public procurement ensures that we have good transparency, fairness, integrity, and open competition by having international bidding and inviting pre-qualified suppliers who are eligible and meet the criteria for public procurement. So public procurement is a critical aspect of supply chain management and having good access to medicines. Effective procurement embodies a few core principles. The procurement agency should be audited annually by an independent body to ensure that it conforms to good procurement practices, because worldwide we know up to 10–20% of public funds are sometimes leaked because of misappropriation and corruption. Luckily, in our member states, we don't have those unfortunate experiences. Effective procurement means that we purchase from suppliers who deliver on time, reliable suppliers, because one of the drawbacks in getting access to medicines is purchasing from suppliers which are unreliable. So we have systems in place to monitor suppliers' performance, and those suppliers have to be paid on time. Reliable payment means having a guaranteed pool of funds to pay suppliers. And it's one of the weak areas in some of our countries. And that is why international organizations, we promote national health insurance. National health insurance will ensure that there's a guaranteed pool of funds to ensure suppliers are paid on time. We cannot always rely on the government's consolidated budgets. But wherever you use government's budget, is to remind our governments that medicines are one of the most cost-effective ways of investing in our healthcare. Separation of duties means that persons responsible for procurement should be separate from persons in finance so that we don't have conflict of interest. Recognized product quality is built into the system by ensuring that in our standard bidding documents, we have clauses to ensure we procure from international suppliers who manufacture according to GMP. And of course, we have our backup post-market surveillance program, which could be done by our quality control laboratory in Jamaica. Effective procurement also means purchasing on time so that we have a purchasing schedule and a large framework agreement so suppliers could supply in accordance with our purchasing schedule. Effective procurement also embodies transparent and written procedures so that suppliers will ensure that they conform to international best practice and that any disputes, any disagreements are settled according to international law and in an amicable matter. So therefore, procurement ultimately ensures that we have the right products at the correct quantities and at internationally competitive prices. When we look at procurement, a number of reasons can be attributed for late consignments. And if we look at our scheme here, one of the most important reasons or common reasons for suppliers or for consignments being received late in our countries is when suppliers place our purchase orders on credit hold because of default in payment. It's one of those maladies which affect many procurement systems, and I dare say in the Caribbean. So again, we spoke about reliable payment. Reliable payment will decrease the incidence of suppliers placing our purchase orders on credit hold. Okay. The next important factor which contributes to late arrival of goods is when countries order on time and do not meet the requisition ordering schedule. That's also an important factor. Most of our suppliers, 90% of medicines used in the Caribbean are imported from extra-regional sources. Suppliers located in Europe, North America and Asia, mostly India. And therefore, we have to compete with relatively small orders. When we place our purchase orders to distributors, and 80% of our suppliers are distributors located in Barbados or Trinidad. And therefore, we have to, there's a long supply chain. And this can contribute to suppliers having stockouts on the international market, back-ordered items, and because we have to compete with large orders from other countries. Inaccurate member states forecasts, that is, whenever the discrepancy between our forecasted quantities and what we actually purchase, sometimes there's a gap. And if there's a big gap between our forecast and our purchase quantities, suppliers can overstock or understock, and this could also cause issues for late consignments and disruptions in our supply system. So you can see there are many factors which can ultimately contribute or affect access to medicines at the point when the patient presents a prescription. Once we procure, we need to have good inventory control practices, and factors which should be considered in calculating the reorder quantity is the lead time, which is the time it takes to place the purchase order to the time when the order is received in the country. Safety stock is that buffer stock, that judgment, which means it's a management decision. Extra stock we keep always in case there's a pandemic, suppliers have an extra, lead time is lengthened, and unforeseen circumstances. Stock position is just your position in stock in months. Procurement period means the period of time you are purchasing for. And typically in the Caribbean, we probably purchase every 4 months or sometimes 6 months, occasionally annually for low-cost items. Minimum stock is that stock when that level reaches that minimum balance, also called reorder quantity, that is when we need to place the purchase order. If there's a delay in placing the purchase order on time, it can result in stockouts. Maximum stock is what it is, the maximum stock at that given time. Average monthly consumption is the common parameter and denominator which we use in inventory control. So if we look at our inventory control model, on the x-axis here, we have stock on hand. Y-axis, we have time in months. So if you look at the ideal inventory model, this is stock on hand. Stock continued to be used as they have been requisitioned and consumed by patients. At this juncture, when we reach what is called the reorder level or the minimum order level, this order should be placed. While the order is placed, the lead time is being consumed, the order is received and the stock goes up. So this interval here is the lead time, and it's important that if suppliers have a long lead time than expected, we may run into problems, but we use our safety stock to buffer. But the safety stock is a function of the lead time. So it's usually 1/3. For 3-month lead time, we have 1 month of safety stock. So we have a few standard inventory formulas, which are using the back end of our computers, in the back end of our procurement, minimum stock levels, which is also the point where the stock should be reordered, which is your lead time, multiplied by CA, your monthly consumption, plus your safety stock. Maximum stock would be your minimum stock, the formula above, plus the procurement period multiplied by your monthly consumption. And our forecast is your requirements minus stock on hand plus stock on order. So this is just information which we use in the back end of our programs to mathematical formulae to ensure that we have medicines available on hand. And therefore, you can see if any one of those parameters are violated, if we don't order in time, we have poor information feeding into the system. Of course, it will spew out incorrect information. The adage, garbage in, garbage out. So we've spoken about distribution, procurement. Sorry, we've spoken about selection, procurement. Once the medicines arrive, then we have to distribute the medicines. And a good distribution system means having a reliable supply of medicines to the peripheral health institution, health centers, and clinics in a cost-effective manner. Before medicines are distributed, they need to be warehoused. And this is a picture of a warehouse from, just a snap picture from the British Virgin Islands. And I think Gracia Whitley is in the conference call. I'm not particularly promoting BVI, but it's a good practice, relatively modern warehouse with shelves which could be contracted. But the point is, it's important for us to invest in a modern warehouse, because if you spend millions of dollars to procure medicines, medicines are perishable. The worst enemies to medicines are heat, humidity, and moisture, and they should be stored in proper warehouses. So in terms of distribution, if you look at the schematic diagram, we have procured the medicines. They must be cleared from port. Medicines should be cleared from port 7 days maximum from the time the medicines receive in port to the time the medicines are cleared out of the port, to avoid medicines being stored under adverse conditions in the port environment. Medicines should be cleared from port, received, inspected. We spoke about good inventory control. And in the modern practice now, we are getting away from bin cards and stock cards. Electronic inventory systems are what's recommended for good storage. Medicines should be requisitioned by the peripheral health centers and the hospitals, delivered, dispensed to patients, and of course you have a consumption report. So you could see healthcare practitioners, persons in the webinar, a lot goes behind the scene. Medicines are concrete substances, and healthcare workers get demoralized when they're not available. but most of the medicines, 90%, are imported from extra-regional sources. And despite the best of intentions, occasionally we may have some disruption. A well-distribution system ensures, nevertheless, a reliable medicine supply system. We need to maximize transportation by having a distribution schedule so that our transport has a schedule so that we will deliver medicines to the north of the island, to the one, on a particular day, west, east, south. So we have a distribution schedule in such a way that the transportation to the peripheral health centers are maximized. And in that way, we maintain medicines quality, that the delivery vans are suitable and are protected from the elements. We need to have good distribution system when they leave the central medical warehouse to the peripheral health centers. We have signing off on the invoice at the central medical stores, to receiving at the health centers and the hospitals, to reduce theft, fraud, and pilferage, because medicines are relatively small, have a high market value, easily concealed, and unfortunately, we have had instances in our countries where medicines destined for the public sector, unfortunately, mysteriously finds itself in the private sector. So we want to make sure that we reduce pilferage, and also to reduce spoilage and expiration and obsolescence. So a good distribution system will be all of the above on this slide. With distribution, medicines then are prescribed. And I want to bring us now to the next concept of pharmacovigilance, which is the systematic reporting of adverse medicines reactions. Pharmacovigilance could be disaggregated. Pharmacomedicine, vigilance means alert, watchfulness in respect of danger. And what is pharmacovigilance? It's really to improve patient care and safety, is to ensure that medicines benefit outweigh the potential risk, and it's important to assess the benefit, harm, and cost effectiveness of medicines. Why spend our time to report on adverse reactions? And CARPHA has an adverse reaction form, which I will share with you shortly. It's a form that we are asking you, which is not used sufficiently, but we would like to promote it and to ensure that once we prescribe medicines, we have a duty of obligation to report any clinically significant adverse reactions. Why? Because before market authorization, there are limitations to when medicines are, what we know of medicines in the pre-marketing phase. Medicines are used of short duration, and some adverse reactions can occur. They have type C reactions, which can occur several months or several years after the medicine has been used by the patient. Certain tumors for oral contraceptives, for example, during the pre-marketing phase, which is used for limited numbers of patients. We use pediatric patients or pregnant patients or patients with psychiatric disease. So in the pre-marketing phase, the patients are controlled, the conditions are controlled. The patients, in terms of the size, numbers of patients in phase 3 clinical trials, approximately about 5,000 patients are used. And therefore, in post-marketing, it's important to monitor these adverse reactions, because for rare adverse reactions, which occur 1 in 10,000, we need about 30,000 patients to be reasonably assured that we may discover or detect an adverse reaction or a signal which may not have been reported before in a patient in the package insert. Also in the pre-marketing phase, medicines, say for example diabetes, would be used if patients who are diabetic. But we know when we use medicines in our community, in our hospitals, medicines will be prescribed for patients typically, let us say, for diabetes and hypertension. In our Caribbean setting, up to 70% of our diabetic patients are hypertensive, because diabetes destroys the blood vessels. And therefore, when we use medicines, is what not only what the medicine can do to the patient, but what the patient can do to the medicine, all that affects the adverse reactions. So we need to ensure that we monitor adverse reactions when they are used in large numbers of patients in the post-market. And why pharmacovigilance? Because we are all not born equal. So genetics, diet, culture can affect the way the medicines work in the body, and not work, but move. The pharmacokinetics, for example, say, and for hypertensive meds, it's well known now that our angiotensin receptor agents, our ACE inhibitors, because we don't have an active renin-angiotensin receptor system, we don't respond as well as Caucasians to those meds. So genetics, diet, culture. We know grapefruit juice can affect the metabolism of certain drugs by the oxidative enzyme system. The concurrent use of herbal medicines, all those factors can affect the outcome of the adverse reactions in our Caribbean environment, and hence the reason why we should monitor adverse reactions in our setting. So it's an important tool for the safe and effective use of meds. So just about 4 or 5 more slides. I'm showing right now the VG-CARIB reporting form, and I'm going to encourage all of us, in case you have not seen it before, it's online. It's one of the arms of the Caribbean regulatory system, and it's easy to fill out. The first part is for the meds, the generic name, the brand, the batch number, the expiry date. It's important to put the brand, because different brands may exhibit different adverse reactions, because the different excipients, apart from the active pharmaceutical ingredient, may contribute to the adverse reaction of a med. So it's important, different brands of the same chemical moiety may give different adverse reactions. So we need to make sure we have this. So section A of the form is to fill out the medicine. Section B is the patient information. It's anonymous, patient initials, the gender, date of birth, dosage, indication, what it is used for, whether the patient, what the patient, the outcome, and other aspects on the patient. And lastly, we have the initials of the reporter. So it's a form, and you could attach pictures of the form, pictures of the medicine to the form and upload it. And it's self-explanatory in the next slide how to use. So it's just a pitch that in case we encounter significant clinical adverse reactions to our meds, then it's an opportunity to report adverse reactions. Rational medicines use, that slide will talk about after medicines have been in the prescribing function, is to ensure that we adhere to our clinical guidelines. Sometimes as practitioners, we feel a bit handcuffed that we have clinical guidelines, but clinical guidelines is a guide, and most patients will fit within the domain of the clinical guidelines once we are guided by our essential medicines list. And the essential medicines list promoted by CARPHA for the treatment of diabetes has all the main categories of medicines used for diabetes, the biguanides, the sulfonylureas, the gliptins, and the DLP. All those medicines are available. They might differ according to each country. For rational medicines use and adherence, we want to make sure we have the healthcare team approach, that the nurse, the doctor, the pharmacist, all of us are involved in reminding and encouraging patients to use the meds and to adhere to the prescribing and dispensing information, because up to 50% of patients, up to 50% of patients don't take medicines as prescribed by the physician, and therefore we need to ensure it's a good opportunity for our diabetic patients who come time and time again. Don't take them for granted. Keep on reminding and repeating and reinforcing the need to take the meds, because patients get a little bit, they get medicines wary, and they always want to get medicine holiday. The use of independent information, because we know that the information in the package insert can be skewed in one direction. Even the information provided by the drug representatives sometimes are not always balanced, and we need to make sure we have good independent information. So the last point, the last aspect of getting access to medicines is to measure the efficiency and the effectiveness of our procurement and supply systems in all our countries by using standardized indicators which measure change and measure the important dimensions of the performance. Those characteristics should be valid. That means important, useful, reliable. Reliable means whoever is the researcher, whoever researcher who is conducting and collecting data, the information should be fairly consistent and the information should be measurable. So in terms of M&E, and to measure the effectiveness, because I find in the Caribbean, we don't spend sufficient time and we don't pay enough attention to monitor the effectiveness of our supply system. You have, for example, this medicine is out of stock, but is it out of stock and for how long? So this slide is a summary of indicators which are available, which we use in some systems to monitor the efficiency. Indicator one is we could measure in a mathematical way the percentage of time which medicines could be out of stock. The second indicator, we could measure the service level of prescribed anti-diabetic meds or any NCD meds. So I'll just focus on 1 and 2 because this indicator is easy to do, applicable to our discussion this evening. And the availability of prescribed medicines measures the percentage of medicines which are prescribed by the physician, say on 30 prescriptions, that's the magic number, in at least 6 public sector pharmacies. And the numerator will be, if we count the number of medicines dispensed, say diabetic meds, over the number of medicines prescribed, we'll get a simple number, and that will give an idea in terms of the percentage of medicines which are dispensed to our patients who present prescriptions for NCDs, and the percentage which are available. Because sometimes you hear medicines are unavailable, but to what extent they are unavailable? So we have systems in place to measure them in a mathematical way. And I know my time is up, it's almost half an hour, but just 2 more slides. This slide here is the data for St. Lucia, a typical country over the last 4 or 5 years, whereby we strive to, the benchmark is at least 85%, and St. Lucia has been recording 90% availability of prescribed medicines. That is, of every 100 medicines prescribed in the public sector, 90% are available at the point of dispensing, which is good. So in summary, access to medicines can be encapsulated to ensure that we buy medicines at affordable prices, benchmarked against the international median price. We have what is called rational selection using sign level of evidence, evidence extracted from double-blind clinical control trials. We have sustainable financing because apart from food, the next most important item in somebody's household is your medicines. And we tell governments to have a wealthy nation, to have a good GDP, we need to have a healthy population. And this also embodies a reliable health supply system to ensure that we have good access to medicine. So colleagues, what I've tried to do is to talk about the main systems and parameters which constitute access to medicines, selection in a rational way, having the best medicines available for use in our system. They are procured in a cost-effective manner. They are warehoused properly. They are distributed. They are prescribed in accordance with the treatment protocols by CARPHA, and any adverse reactions are reported using our portal, which is by the Caribbean Regulatory System, DigiCarib. I thank you very much for listening to me, and thank you for your participation. Over to you, Pat.
Thank you very much, Mr. Burnett, for an excellent presentation. Honestly, I felt like I was in my element with your last, maybe about 4 or 5 slides when you were talking about M&E. So, you know, it was a perfect ending for me. And I'm sure also for our participants. Thank you very much.
Thank you.
We now move to our panel discussion with the member states. We have representatives from Jamaica and Barbados. And the panel discussion will, of course, focus on ensuring essential access to essential medicines during the COVID-19 pandemic. Our panelists are Mr. Ainsley Jones and also Ms. Pamela Payne-Wilson. I will take this opportunity to give you a brief introduction for both of our panelists before the session begins. Mr. Ainsley Jones is the Director of Pharmacy Services at the Southeastern Regional Health Authority, Northwest Ministry of Health and Wellness in Jamaica. He is a pharmaceutical service delivery leader with 12 years experience as a registered professional. He has honed his skills as a dynamic servant leader, having served at every level in the sector. Ainsley's unique value is demonstrated through his eye for details, strong analytical skills, and broad knowledge on the sector. As a leader, his distinguishable characteristics are emphasized and empathy and the value he places on equity. That is why his focus also always has been on transforming the way clients experience pharmaceutical services in Jamaica and also in the wider region. He leads from his core values of excellence, transparency, accountability, empathy, and integrity. Of course, because he believes it is not just what you do, but who you are that makes you a professional. Ainsley holds a bachelor's degree in pharmacy and is also currently enrolled in a master's of business administration program at the Herod Wyatt University. Our next panelist is Ms. Pamela Payne-Wilson, who is the Assistant Director of Professional Matters at the Barbados Drug Service. Ms. Wilson is one of 2 Assistant Directors at the Barbados Drug Services with responsibilities for professional and education matters. Ms. Payne-Wilson's professional qualifications includes a Bachelor's of Science in Pharmacy from the University of Alberta in Canada and an MBA from Burnett University in London. Her responsibilities include Secretary to the Drug Formulary Committee, training and development for staff through continuing education programs, public lectures, and other administrative duties. Mrs. Payne-Wilson has 33 years experience in the service, and she is passionate about providing quality services to all stakeholders. So I invite both of our panelists at this time. We have a few questions that I will be posing to our panelists. The panel discussion will take an approximate time of about 15 or so minutes. So the first question to our panelists is, what is the system that is in place in both Barbados and Jamaica to provide pharmaceutical services to persons with diabetes and other non-communicable diseases? I will first invite Mr. Ainsley Jones to respond to the first question. Thank you. Mr. Jones, I think you may have to unmute your mic.
Yes. Pardon me, are you hearing me now?
Yes, great, excellent. Thank you, take it away.
Yes, thank you so very much, Moderator Cummins. And let me say good evening to those of you out there across the Caribbean. And of course, good evening to the panelists as well too. In terms of the system that is actually here in Jamaica, we actually have the National Health Fund, which is an agency of the Ministry of Health, which is responsible for the provision of pharmacy services in the public sector. And we also have another arm in terms of the University of the West Indies, which also runs its own pharmacy as well too. But I'll tell you about the main public health system here in Jamaica. So the pharmaceutical care is delivered through the Pharmacy Services Division of the Ministry of the National Health Fund, which is the agency of the Ministry of Health. And here we have two particular divisions that offer this service. We have our warehouse management branch, and we have the drug serve department as well too. Now, our warehouse management branch, it actually works closely with our procurement division and is responsible for the procurement, the warehousing, and the distribution of pharmaceuticals, medical sundries, X-ray, suitors for use in our state-owned hospitals, health centers, and so forth that are operated, of course, by the NHF. Now, the drug serve department is the department that is responsible for the management of approximately 106 public sector pharmacies located in hospitals and health centers mainly. Now, each pharmacy is actually managed by a pharmacist, and that person is responsible for the delivery of high quality pharmaceutical services to public sector patients, and they also assist in achieving positive health outcomes here in Jamaica. So that's the main system which we actually have in place to ensure the delivery of pharmacy services across the country.
Okay, thank you very much, Mr. Jones. Mrs. Payne-Wilson, over to you.
Good afternoon. Thank you very much. I wish to express indeed gratitude to the staff of CARPHA, and thank you for the opportunity that Barbados can be part of this panel discussion. In terms of the service that we offer in Barbados, we have what is called the Barbados Drug Service, and we service both the public and the private sector. In the public sector, we have 15 pharmacies, 9 in polyclinics, which offer the full gamut of our medical services. Then we have 3 outpatient clinics and 2 district hospitals. In the district hospitals, those are the only 2 that the public will not be able to access. Those are basically for inpatient use. The outpatient clinics and the polyclinics, they offer for the general public in Barbados. In addition to our public sector arm, we have the private arm we call the private participating pharmacies, and that's part of the special benefit service program. So what happens within the private sector is that patients would take the scripts to them and they would pay a dispensing fee. And then that's the patient would pay a dispensing fee. And then the pharmacy would request reimbursement from us, Barbados Drug Service, in terms of the actual cost of the drug. So that's the public and the private sector arm in terms of the dispensing of medicines. In order to benefit the program, persons must be Barbadian nationals or permanent residents, and they have to produce a Barbados identification card in order to benefit from the program. We have basically 3 colors of prescriptions. We have a blue, pink, and a yellow. The blue prescription is written in the public sector so that we'll be able to distinguish the public from the private. Pink prescriptions are written in the private sector, and then we have the yellow prescriptions, which are written at the Queen Elizabeth Hospital. These prescriptions within the public sector, they can either be filled within the same public sector, within the polyclinic or outpatient clinic, but patients have the option also of taking them to the private sector. So if they take them to the private sector, they would have to pay that dispensing fee. But if they remain in the public sector, they get the medication free of cost. Similarly, with the yellow prescriptions from the Queen Elizabeth Hospital, they can have them filled within the public sector. If they take them in the private sector, they have to pay the full cost. So you may have some persons taking them to the private sector as a matter of convenience or time in such instances. As I said earlier, the prescriptions that are filled within the private sector, we have a form, a reimbursement form, which the pharmacists would have to complete, submit that to us on a monthly basis, and then they're reimbursed the following month. The drugs that are basically, or what we call our benefit drugs, which includes diabetes, includes things like hypertension, asthma, epilepsy, cancer, and glaucoma. Those are our 6 benefit categories. And usually you would find that mainly hypertension is number 1 in terms of the usage pattern, the number of patients, clients in Barbados, followed by diabetes. The supply through the program, we get our drugs, as Mr. Burnett had described earlier, in terms of the whole tendering process. We started off initially with annual tenders, but now we have moved to tenders every 2 years, and this has moved very smoothly. We have the formulary committee, which is currently a 13-member committee. That committee makes recommendations to the Minister of Health and Wellness in terms of the drugs that should be made available for these chronic illnesses, and generally all of the formulary drugs. Once approval is given, the information is then fed into the Drug Tenders Committee so that they, at the appropriate time, will send out to the tenders for bids, and the selected products through the tendering process is then given in the booklet, which we call the Barbados National Drug Formulary, and that comes out every 2 years. So the formulary, once a drug is in the formulary, persons can benefit from these particular drugs. But in terms of the benefit drugs, which we said earlier was the cancer, the glaucoma, the epilepsy, hypertension, diabetes, glaucoma, these drugs are specific for benefit categories. Benefit categories also include persons who are under 16 or over 65. So if we have a pink prescription written in the private sector, a person under 16 years or over 65, or a sufferer of one of those 6 ailments, they can get the medication in the private sector free of cost, with the exception that they'll be paying the dispensing fee. But if the person is out of those categories, but it is a formulary drug, the patient would have to pay the full cost of the drug. That's in terms of the public sector and the private sector and how the services are offered. So basically, that is it in a nutshell in terms of our program and our offerings in terms of our chronic non-communicable diseases, with diabetes being our 2nd highest user, but hypertension is our number 1. Thank you. You may need to unmute that.
Okay, great, thanks. Yes, as we already have the floor, I will invite you, of course, to respond to the next question coming up. And the question is, does Barbados and for Mr. Jones, Jamaica, the Ministry of Health and Wellness have an essential medicine? If so, which drugs, and how does it compare with the WHO guidelines? Mrs. Payne-Wilson?
Okay, thank you very much. We do not carry an essential medicines list, but our Barbados National Drug Formulary is pretty similar in that the whole selection process is geared on the WHO guidelines in terms of the relevance of the particular drug to our prevalence of the illness within Barbados, has to have proven efficacy and safety, adequate scientific data and evidence of the drug's performance in a variety of various settings, adequate quality, favorable cost-benefit ratio, and also the desirable pharmacokinetic properties. So basically, that's the selection criteria. The Drug Formulary Committee, as I stated earlier, that's the body that deals with the actual selection of which drug should and should not be included in the formulary. And we would have done the last review about 3 years ago, that we would have done a review. So about every 4 or 5 years or so, we would do a review, a general review. But monthly, the Drug Formulary Committee meets and takes into considerations any requests that may be made from physicians in terms of drugs that they would wish added. And once a decision is taken, the recommendation would go to the Minister of Health and Wellness for his approval. Thank you.
Okay, thank you very much. And Mr. Jones?
Yes, thank you so very much, Ms. Smith-Payne. Yes, in Jamaica here, we do have an approved list of vital, essential, and necessary drugs, and that is developed by what we call our Central Drug and Therapeutics Committee at the Ministry of Health. Information is usually fed to this committee from the drug and therapeutics committees across the different hospitals in Jamaica, and then they make a decision as to what should be added to the list, what should be removed, and then the Minister of Health, of course, will approve the list. So we do have an active list of vital, essential, and necessary drugs. In terms of comparison with the World Health Organization recommendations as it relates specifically to diabetes, I would have done a review, a basic review of what the guidelines were or the recommendations were from the World Health Organization. And it would have indicated that in terms of first-line therapy, the main recommendation is really metformin. And on our VEN list, metformin is one of our mainstay as it relates to treatment of diabetes, where metformin is contraindicated in patients. The World Health Organization indicated that the next choice would have been sulfonylurea. And on our drug list here in Jamaica, we do have 2 sulfonylureas. We have glyclazide, which is a 2nd generation sulfonylurea, and we have the only 3rd generation sulfonylurea, glimepiride as well too, on that drug list. For 2nd-line therapy, the World Health Organization specifically recommended use of a sulfonylurea addition, of course, and as indicated, we actually have 2 on our VEN list. For 3rd-line therapy, the World Health Organization indicated that human insulin should be considered. And on our VEN list here in Jamaica, we do have human insulins, including regular insulin, our insulin R, which is short acting. We have our NPH, our insulin N, which we know is intermediate acting. And we have pre-mixed human insulin, that is our M3 or 70/30 insulin. We also have on the VEN list insulin glargine, which we know is a long-acting insulin as well. I'd just like to point out as well too that the World Health Organization indicated that glibenclamide should not be given to patients over 60 years old. And from my remembrance, the last time we met, we would have removed glibenclamide from our VEN list here in Jamaica. So the 2 sulfonylureas that we have on the program are actually glyclazide, a 2nd generation, and glimepiride, which is a 3rd generation. As we all know, glibenclamide has a very deleterious effect in terms of it can cause hypoglycemia, especially within the elderly patients. So we removed it.
Okay, great, thank you. And moving right along, the 3rd question, and Mr. Jones, I'll ask you to respond first. How has the provision of pharmacy services to persons with diabetes and other NCDs been affected by the COVID-19 pandemic in Jamaica?
It has impacted our patients, it has impacted our system, and it has impacted, of course, our diabetics and patients with chronic non-communicable diseases. Now, at the NHF, as managers, we are required to perform ongoing ongoing environmental scanning. Now, hence, in January of this year, our procurement and warehouse teams projected the situation in China, that it could have, lead to drug shortages, and we actually acted quickly in implementing measures to increase stock levels, increase orders with existing suppliers, and of course, we engage additional suppliers as well too. Now, what this did is that it provided buffer stocks that cushioned Jamaica from serious drug shortages when the global supply chain disruption actually intensified, as some countries, they closed their borders and banned exports of certain drugs. Now, the result was that while supply of some drugs ran extremely low, complete stockout was limited and or short-lived as it relates to these drugs used in diabetics and other non-communicable diseases. In fact, based on our quick response, the NHF was actually able to dispense 2 months supply of medications to persons with diabetes and other chronic non-communicable diseases. And that limited the need to visit the pharmacy. Now, in instances where supplies got low, the modus operandi was to ensure supplies are available for institutionalized patients and limit the supply to outpatients until stock levels were actually replenished.
Yes, thank you very much. Pamela?
Thank you. Just before I go on to the last question you posed, I just wanted to mention that within our formulary, we have 3 tiers of drugs. We have what we call the category A, which is full formulary, so any person can benefit from the category A drugs. And then we have the category B drugs, which are only available to persons upon the submission of a request from a medical officer of health or a consultant, and they're reviewed by the Barbados Drug Service. And once approval is given, then these drugs can be made available in the public sector. Category C drug is a drug that is not purchased within the public sector, but it is given priority in that persons can benefit from a cheaper cost, in that duties and so on will be waived in these category C drugs. So basically, in terms of the anti-diabetics and so on, it would be the usual glycoside, the glyformin, and the zinc suspensions. And the category B drugs, we are looking now at the Lantus and the Galvasmet, Apidra, and those drugs that would be available in terms of the category Bs. Now, in terms of your question, how these changes would have impacted. And with regards to the COVID-19 and the pandemic that we are currently in, initially we had just crowds of persons at our pharmacies. So we had to take quick action in terms of how are we going to maintain our physical distancing and still allow good quality service to our clientele. What we did, as our other speaker panelists said, that we would have given 2 months supply of medication to patients so that they wouldn't have to be returning every month, reduce the queues. We also offered drop-off service and also call-in prescriptions. So persons were able to leave the prescription, have it filled, and then come back at a time when the pharmacist would call them and say, okay, you can pick up. Or in cases, persons would just telephone in and they would get the medication or the repeat completed that way. The Queen Elizabeth Hospital, they offered what we call the mail prescription delivery program through the postal service, so that persons can actually get the medication. They would drop off the prescription and they will have the medication delivered straight to their home through the Barbados Postal Service. Now, what other measures we put in place? That's mainly with the availability of our supplies, because in some cases, because of the closing of borders and so on, we were running low and we saw a possibility of stock outages. So what the government will have done, give us the go ahead to purchase 6 months supply of medication, especially those in the non-communicable diseases. and we would have had storage. We had some storage challenges initially since we are not equipped for this, but we would have worked with other government institutions and we got some storage, additional storage, so that with the 6-month supply, it was a backup in case the local distributors were unable to provide. Then we would have the NCD drugs available that we can supply from in-house, and that worked out quite nicely. It was a challenge for us because we're not really used to stocking and issuing and distributing, but we were successful in getting it done over the last months. Any additional supplies, because at one point in time we were very low on the insulin, but we made some necessary communications and we got stock of that in a timely manner as well. There's some pharmaceutical companies overseas that we were able to work with, and they supplied stock that was going low, but we are thankful to all the support in terms of the governments of the various islands as well, that worked with us and ensured that our supply of pharmaceuticals, especially in the NCDs, that they were always available to our public. Thank you.
Okay, great. Thank you very much. Moving right along, the next question is in regards to the measurements or the measures, sorry, that have been put in place by the Ministry of Health and Wellness and the National Health Fund to put in that have been put in place measures to ensure that access to medicines for persons with diabetes and other NCDs during the pandemic. What measures have been put in place? This is Payne-Wilson, please continue.
Okay. Well, basically what I would have just pointed out, those are the main measures that we put in place. We also sought to, in terms of ensuring physical distancing and so on at the polyclinics, we would have erected external space in terms of erecting tents at some of the various polyclinics that patients can sit or wait there, because within the previous space in the polyclinics, it would not have been adequate to facilitate the physical distancing that was needed. So the external tents, and some of them are still in place, some may have been taken down, but that is one of the measures that were put in place, along, as I said, with the calling, the postal delivery service in terms of the medication delivery service. Those were some of the main things that would have been put in place to see us through some of the periods within the COVID-19 pandemic.
Okay. Thank you very much. Mr. Jones?
Thank you so very much again, Mrs. Smith-Cummings. Now, in terms of access to essential medicines for our diabetics and other patients with non-communicable diseases, as a customer-centric organization, and prior to the COVID-19 pandemic, the National Health Fund had actually launched a suite of what we call alternate service options. And these included our programs such as the acronym DOPUS, D-O-P-U-S, is for our drop-off and pick-up service. So the patient does not have to come to the pharmacy to sit and wait for long periods. All they need to do, come in, they drop off the prescription, make arrangements with the pharmacist as to exactly when they want to come back to pick up that medication. And this is actually very convenient for our patients that are working. We also had launched our scheduled refill program. And this is specifically for the patients with non-communicable diseases who would have been given prescriptions with multiple repeats. So these patients, again, do not have to come into our pharmacies, because one of the issues that we recognize is that in terms of delivery of the service, it was not at the level that we wanted it to be. The customer experience was not the best because we recognize that the pharmacies were overcrowded and patients were waiting for up to 3-4 hours. And so we had to put in some measures to reduce our customer wait time. The scheduled refill service allows patients' prescriptions to be refilled after contact is made with these patients. And one of the things that we recognize as pharmacists that this helped us with was that it allowed us to see the patients who are really not compliant with their medication, so that specific interventions could have been put in place to assist these patients. We also had launched our private sector public partnership program, where patients do not necessarily have to access government drugs through our public sector drugstore pharmacies here in Jamaica, but they can actually go to these private pharmacies. We supply the private pharmacies with these medications, and they would pay a minimum cost at these pharmacies in order to access their medications. And then we had launched our revolutionary Quick Prescript program. And the Quick Prescript is actually an app that is available on our App Store or the Google Store, and patients can actually stay in the comfort of their homes and submit their prescriptions to us using a mobile phone. And this is very convenient for them. Now this they can do, 24 hours per day, 7 days per week. For those patients who would not have a high-end cell phone to do this, we actually have what we call our Quick Prescript kiosk at the pharmacies, where again, when they come, if they don't necessarily have to interact with the pharmacy staff, they can come and they can use the kiosk to submit their prescriptions, and then we will communicate with them via electronic means to let them know exactly when to come in and pick up their prescriptions. Now, I just want to indicate that since the pandemic started, on March 10, our Ministry of Health and Wellness here in Jamaica would have confirmed the first case of COVID-19. And the first quarantine order was actually declared by Prime Minister Andrew Holness back in March. And I think that was March 13, 2020. Now, steps, of course, were immediately taken to prevent the risk of community spread. And that included the dispatch of health team to community of the patients for assessment and, of course, for provision of health care and initiation of public health measures. Now, the NHF's response was that, the mobile pharmacy, because we actually have a mobile pharmacy as well too, it was dispatched to these quarantine communities to provide pharmacy services throughout the period of the quarantine. The mobile pharmacy is actually equipped with all the amenities needed to operate a pharmacy, including storage, cold storage for things like insulin and other thermolabile products. Now, in terms of the stay-at-home order, which was issued by the government, we all know that data suggests that the older population is actually more at risk for having very high probability of, dying if they contract the disease. And persons with comorbid conditions, we know as well too, those with the diabetes and the hypertension, obesity, and respiratory illnesses have a higher probability as well to of having serious effects or of dying from the disease. So the first stay-at-home order here in Jamaica was back in March 25th, I think it was issued by the Prime Minister. Now, in order to ensure access to essential medicines, the NHF medication delivery service was actually conceptualized and implemented for those vulnerable patients as at April 2020. When I checked back the numbers up to October 31st, we would have actually have completed over 25,000 home deliveries. And these deliveries are done through the NHF mobile pharmacy, through government vehicles, through delivery contractors. Our community health aides also assist us with these deliveries, and of course, our public health nurses. And the service has actually mushroomed and has continued throughout the past months. And the delivery service is actually bolstered by what we launched recently in terms of our telepharmacy services. So when the medications are delivered to the patients, the pharmacists actually make contact with these patients to assist with information as it relates to drug information and other information which is pertinent to the patient. We also had launched our Ask Your Pharmacist program. So if a patient is at home and a delivery is made and the patient needs information, the patient can actually call our pharmacists to get additional information. Now, the Ministry of Health also assisted the National Health Fund greatly because the drug budget was actually augmented with additional funds to procure, warehouse, distribute, and ensure the availability of adequate supply of essential medicines. Emergency funds were actually provided as well too and allotted to secure access and delivery of essential medicines to public sector patients. And then of course we instituted rational dispensing, and this was monitored in keeping with good clinical dispensing and inventory management practices.
Okay, great. Thank you very, very much. Your responses flowed right into the next question as you identified some of the measures that you both identified, some of the measures that have taken place to ensure that there's still access to medicine even during the COVID-19 pandemic. I want to ask though, and like I said, you've already gone into it, if you could both identify some of the lessons learned from this and possible promising practices from the pandemic's response, or from the response to the pandemic. You could go, as you have the floor, Mr. Jones, you can proceed.
All right, thank you so very much. I think in terms of the lessons learned, the use of technology in the provision of pharmaceutical care services is absolutely essential to guarantee continuity of care in public health emergency situations. And I mean, based on what has happened over the past few months, we have really recognized that. Now, in addition, the unexpected closure of various country borders can significantly impact the ease of accessing supplies of essential medicines. And we know that this will adversely affect patient care and health outcomes. Therefore, good inventory management practices are always crucial to ensure the maintenance of adequate supplies of essential medicines over, of course, a reasonable period, because we know there are always instances where we have budgetary issues. And then, of course, the general acceptance by both patients and pharmacy staff that the use of technology in submitting prescriptions and the provision of counseling through the telepharmacy and the Ask Your Pharmacist programs, even though they were recently launched, they are very young, but it is really promising. And I think those are some of the major lessons we have learned thus far.
Okay, thank you very much. And Mrs. Payne-Wilson?
Yes, thank you. Okay, in terms of the takeaway messages for us, as Mr. Jones said, the technology, having robust technology in place, basically to get the medicines, the medications out to persons, so we would actually be operating in a paperless environment so that we would be able to maintain physical distancing. We really have to boost up on our technology, and we're looking at that in terms of our upcoming financial years so that we can have the necessary monies in place to boost our technology. What we also realize is that in terms, as I mentioned earlier, with regards to the delivery service, we want to look seriously at that in terms of using the postal delivery service to get our medicines to the vulnerable, to those persons who cannot otherwise come out or have some other problem that they would not be able to collect the medication from the respective pharmacies. We want to implement a warehousing setup in terms of the distribution of pharmaceuticals, because as I mentioned, in some cases with the lockdown, some of our local distributors were not able to supply. So we did get the go ahead and did acquire 6 months supply of medication, which we would have stored and distributed from in-house along with some other external facilities. But this we need strengthening in terms of going forward. And this is a very essential backup for those cases when we will not be able to acquire the pharmaceuticals from our regular local distributors. And that public-private setting a partnership that is that is key to our mainstay in terms of our delivery of pharmaceuticals to the public. So we want to continue our ties with the private participating pharmacies. And what we want to look at in the future is also having that a centralized system for both the public and the private sector, so that patients, everything would be in one location. All of the files would be in one location, and patients will be able to go to any of the public pharmacies and get their prescriptions filled, or even in the private sector, because right now in some cases, patients may go to both the public and the private sector to get the same medication, and we may not always pick it up. But if we have one central location for all of the prescriptions to be stored, then we'll be able to pick up on those, and also patients will be able to go to any pharmacy within the public sector as well. They may get the prescription filled initially at Randall Phillips, and then they may be able to go to Winston Scott to get the repeats then. So that would also improve the whole access and persons being able to get medication and in a timely manner. So therefore, we want to encourage this, and also in terms of our staff, we want to ensure that our staff are safe as well. So in terms of having the necessary PPEs in place for them, in terms of retrofitting our pharmacies to ensure that they are adequately protected, we want to look at that seriously and to work with our staff in terms, because they were out there in the front lines in terms of the pharmacy staff, to work with them in terms of areas that we can improve in terms of the overall provision of service. But we have been very fortunate to have a cadre of staff that goes above and beyond the call of duty. Within these last months, they have been there for us. They have worked tirelessly with the patients, with the clientele, and we want to applaud them all. And once again, I wish to thank CARPHA for the opportunity to share our actual service with the Caribbean. Thank you.
Thank you very much, Mrs. Payne-Wilson. And Mr. Jones, I also want to thank our participants. I know that we have gone over time a little bit, but it was an excellent discussion, and even from the comments from the participants. So I want to really thank you for your contributions, and also for identifying the lessons learned and the best practices that we could seek to document in the region of things that have worked well in the regional response to the COVID-19 pandemic. So that was an excellent panel discussion. I want to also remind participants and also open the floor for questions that may have been posed previously. Yes, that may have been posed previously, questions that you may want to ask the panelists. At this time, I will ask all of our panelists and also our presenters to put on their cameras. And thank you very much. Yes. All right. And I also want to take this time to review any questions that persons may have had. During this time, we have quite a number of comments that have persons have indicated that it's a very impressive session, very excellent discussions and presentations. So we want to thank all of our participants also for their contributions and their comments in regard to the session. I'm just checking. Let me see if we have any question here that may have not been answered. I know that some panelists and also presenters use the opportunity to respond in the Q&A directly to the questions that were posed. So I just want to confirm that all questions were responded to. Presenters?
Yes, we responded to most of the questions.
Okay, then great. Thank you very, very much. I also, if we have no other. Okay, so the questions, just to note some of the questions that were asked, included, has foreign exchange availability been impacted by COVID-19 to purchase much needed drugs for the populations in the Caribbean. Also, in regards to another question was in regard to, can we say if there's any effort that to use epidemiological data from member states for forecasting medicines that are needed, especially for NCDs to avoid stockouts and treatment failure? And if so, what are some of the sources and how the data itself has been used for that forecasting? Right. So even just as we close up, I'll just ask both of those panelists. I know you already responded to it, but if you could just take maybe a few seconds, just give us a few seconds synopsis of the responses to those questions.
Okay, I could just make a quick response with regards to forecasting. Forecasting is perhaps the most difficult area in procurement and medicine supply chain management. It's definitely one of the most difficult areas, and it's all over the world, not only in the Caribbean, in most countries, because there are two main methods. Past consumption method, where we look back at what was used and we try to make some corrections and forecast for the future. But even if we use all the mathematical formulas, sometimes doctors turn over prescribing changes, and those things tend to affect the forecasting. So, but if we, and it's not an easy subject, but if we take some more time and we put in all the parameters in, we could come as close as possible to narrow the gap between the forecasted quantities and what we actually purchase. We look for about a 75% ratio. In other words, of what was forecasted, we should procure about 75%. The other method of forecasting is the morbidity method, where we could use numbers of patients, dosage forms, define daily doses. Those morbidity works really good, especially for vaccines. Excellent for vaccines. So for example, let us say for coronavirus, we could say, for example, we will be using one of those vaccines, the 2 doses, we could predict the population base. And so it works really good for biological products, i.e. vaccines. And for HIV/AIDS, especially antiretroviral medicines. For ARVs, we can use the morbidity method because you have a good idea in terms of the numbers of patients, because it's approximately 1% prevalence HIV infection rate. So you could predict the number of patients, you could predict the treatment regimens. We have a good idea in terms of the toxicity profile, but forecasting is difficult, it's intrinsically difficult, but with some good time and effort, we could do a better job than we are currently doing right now. Just wanted to lay this out.
Okay, great, thank you. And before Nicole responds, I just want to inform our participants that we'll be having an evaluation that will go up, and we're asking participants that even as we are responding to these final questions and we are bringing the session to a close, if you could kindly just take a few moments to respond to the evaluation questions. Thank you very much, Mr. Burnett. Ms. Ennis?
Thanks, Pat, and thank you, Dr. Persaud, for the question. So there are a lot of medicines on the market, and even with the 4 products that we selected for this year, there are a wide range of brands in Jamaica alone and in each country. So this is why we used our risk-based criteria and even asked our participating member states to apply to select the particular sample to send to us for testing. We're looking at using the criteria, those that may have had possible quality issues, or those that are widely used, or a brand that's widely used within the country. And so the medicines that are being used by the transitional diaspora population, it could possibly be part of a future PMS program, because we review the list for the upcoming year based on current public health needs. And so even though we have proposed a list for 2021, it will be reviewed to see if it will be adjusted based on, of course, the current situation. With regards to the recalls that of course happened earlier this year for diabetes, we share this information with the Caribbean regulatory system because of course it's important for our PMS and CRS focal points to know of this and share within the ministry. And then with regards to advisory, it would also now be up to the physician, the treating physician, to discuss with the patient about other options that they could be moved to, as long as it's ensured that the replacement treatment will offer the same level of control. And Module 1 of the CARPHA guideline on diabetes gives us some options to consider.
Okay, great. Thank you very much, Ms. Ennis, for your response. We have another question here, and this will be from Ms. Pamela Payne-Wilson. Are a few postal employees trained in handling medicine for delivery to clients?
No, actually, training wouldn't really be required by them because it's just like a delivery of postal mail and so on. So what happens is that the pharmacy would do the necessaries in terms of the packaging, the labeling and everything. We'll put it in a sealed bag, tamper-proof bag, and then the postal service, they would come collect and then drop to the particular client's home. So information, any follow-up, that will be handled directly by the pharmacist. So that will be between the pharmacist and the patient. So basically the postal service, the only main area is for the pickup from the pharmacy and drop off to the client's home. So there's no really no definite interaction in terms of counseling that would have been needed at this point in time.
Okay, then. Thank you very much. Thank you very much, Mrs. Payne-Wilson. Any contribution, any closing contributions, Mr. Jones?
In closing, I'd just like to say that, you know, our response is as pharmacists to ensure the continuity of care. It has to be swift and bold as we manage the care of patients, you know, to really ensure the most positive health outcomes. We have to, as I said before, embrace the technology in periods such as these, because technology actually improves the operational efficiency of the entire dispensing process. It also assists in protecting pharmacy staff from the risk associated with the pandemic. And it also assists, of course, in protecting our vulnerable population from serious illness and even death. And the technology, as we know, it enhances, you know, customer experience. And there are economic benefits to the patients as well too, because they no longer have to find themselves at the pharmacy, find fare and so forth. Just stay in the comfort of their homes and use our quick prescript app to submit their prescriptions to us 24 hours per day, 7 days per week.
Okay, great. Yes, that's very great. And the lessons that we've learned and these practices, what we are able to apply in other, if we want to say, public health emergencies, now that we've been forced in some way. So look at the pandemic and look at opportunities in the pandemic to improve and to make some changes in our systems. So that is great. So I want to, in closing, extend a heartfelt thank you and appreciation to all of our panelists and all of our participants for participating in this webinar as a part of the CARPHA Health Rounds. As a gentle reminder, I want to invite everyone to kindly complete the webinar evaluation that was placed up earlier. We thank you and we look forward to engaging with you in another session. Thank you.
Thank you so very much and all the best. Have a good evening.
All the best.
Thank
Bye.
you very much. Bye. Take care.
Stay safe.
Take care.
Bye, everybody. Excellent. Good job, Pat. Excellent.
You're most welcome. Thank you.
Good evening,
Nice
everybody.
to see you again, Francis.
Yes, Nicole. Wonderful. Let's keep in touch.
Yes, absolutely. Thanks, everyone. Have a good evening.
Thank you.
Everyone. Excellent. Yes.
Bye, everybody.
Bye-bye.
Thank you.